All right, welcome everyone. Give people 1 more second. Looks like we're all here. Great. Well, welcome everyone to the working session on the non-controlled prescription drugs dispenser reporting, as required by Chapter 296, House Bill 1127, Public Health State Designated Exchange Health Data Utility. So before we begin, I have a few housekeeping notes. If you experience any technical difficulties during the call, please contact Justine Springer. Her contact information will be added to the chat shortly. Today's meeting is being recorded, and we are looking forward to having a robust discussion during today's working session. But until we get to the discussion portion of the meeting, please remember to mute yourself. We will not be holding a formal roll call today, but we are excited to have around 60 people register for today's meeting, including representatives from 9 different pharmacies, 11 HIEs, and 5 electronic health networks. So since we're not going to go through a roll call, during the discussion portion of today's call, please introduce yourself and your organization. You're also welcome to update your name in Zoom to indicate your organization. And we've noticed sometimes if you receive a registration link from someone, you may have entered the Zoom under a different name, so just double check your name. And the chat feature for today's meeting is on. However, we encourage attendees to participate in the discussion portion. And we also encourage everyone to focus the discussion on implementation of the law and the regulations. Now, before we begin with today's agenda, I would like to invite our Center Director, David Sharp, to say a few words. David?
Sure, and good afternoon, everyone. And I believe our Executive Director will be joining us in a few minutes. But kick things off, it's just great to see so many folks that are interested in the work that's underway here. Many of you, probably most of you, were on the call we had a couple of weeks ago, and or last week actually. We're very excited to get your input. Today's discussion, there weren't as many questions that we received in the regulations. We received in the proposed informal lots of great comments and some really good feedback. But in terms of where there might be additional information needed from the group, I think you'll find today is there's much less. So there's a possibility we could be giving you back a good bit of your time, but we yield to you all in how we proceed. And again, I would just like to thank you all so much for all the great time and input you've provided us, not only on these draft informal regulations for your comments, but on others as well. So great to see everyone. I'm looking forward to a really good dialogue. So where it exists, we'll see where it takes us. So thanks again. And Anna, I yield back to you.
Thank you, David. So let's begin with an overview of the law. Chapter 296, House Bill 1127, Public Health State Designated Exchange Health Data Utility, passed during the 2022 Maryland legislative session. And this law requires dispensers to report data to the State Designated Health Information Exchange, CRISP, after dispensing a non-CDS prescription drug. Now, a non-CDS prescription drug includes drugs that are not designated as controlled substances by DEA or the Maryland Office of Controlled Substances Administration. And the reporting is also limited to those medications that are dispensed, not those that are administered or filled but never dispensed. And the law requires that dispense information needs to be submitted to CRISP by electronic means without unduly increasing the workload or expense on dispensers, and in a manner that minimizes burden and duplication by being as compatible as possible with existing data submission practices. Now, once the data are submitted and validated, CRISP will make the prescription information available for treatment and care coordination of patients, as well as for public health purposes. So in May of 2023, stakeholders submitted comments on draft amendments to COMAR 102518, Health Information Exchanges, Privacy and Security of Protected Health Information, in support of Chapter 296. And efforts to update the regulations to align with Chapter 296 were put on hold as priority was given to emergency regulations and implementation of another law, Chapter 249, House Bill 812, Health, Reproductive Health Services, Protected Information, and Insurance Requirements. And those regulations are not final. The MHCC has sought input from stakeholders on the implementation of Chapter 296 through the Non-Controlled Prescription Drugs Work Group, which many of you on the call have participated in. And a recent version of the regulations were released for public comment in May, and we received, as David said, only about 19 unique comments on the non-CDS portion of the regulations. And the comment themes generally included applicable uses of the dispense data, clarification on reporting requirements and options, as well as timelines. So let's see, the goals for today's working session. So we will discuss select comments pertaining to the implementation of the non-CDS data repository and the draft amendments to COMAR 1025-18 and consider possible strategies for implementing the law. So during today's discussion, we're seeking feedback on the non-CDS specific regulations, as well as clarity on select comments provided by stakeholders, and also a discussion on strategies to support implementation and compliance. Now, if you were on the call last week, you may have heard we're going to have one more working session in July on other provisions of the draft regulations. On July 30th, we will host another working group to discuss the amendments specific to the reporting of electronic healthcare transactions to CRISP. So we greatly appreciate everyone who reviewed and provided comments on the regulations, and we're looking forward to discussing them further. My colleague, Nikki, is going to pull up the draft regulations, and I'm going to read a summarized comment, and Nikki will have the corresponding regulatory language on the screen, and then we'll discuss the modifications. But before we jump into the comments, we also wanted to highlight the definition of dispenser, which is included in the regulations. And the definition is on the screen, and we just want to make sure everyone is clear on what is included within that definition of dispenser. It should look very similar to the definition of dispenser that is included in the Maryland Prescription Drug Monitoring Program regulations. So it's a person authorized by law to dispense non-controlled prescription drugs to a patient or patient's agent in the state, including non-resident pharmacies. So medications that are dispensed into the state, those dispensers would be included in their definition. And a dispenser does not include a licensed hospital pharmacy that only dispenses a monitored prescription drug for direct administration. It doesn't include an opioid treatment service program. Our definition of dispenser does not include a veterinarian. And then a definition of dispenser excludes those who are issued a waiver that are discussed or that is included in COMAR 1034-1703, which I believe is the Board of Pharmacy regulations. And those dispensers provide specialty services to those exclusively living in assisted living facilities, comprehensive care facilities, and developmental disability facilities. And then as well as pharmacies issued a waiver under COMAR 1047-07 from reporting dispenses to hospice patients specifically.
So, Anna, can we pause for a moment here and let's just give everyone a moment to digest this and see if there's any questions they want to pose to you or any of your colleagues here. Pretty straightforward definition, and probably many of you all are in one way or the other familiar with the reporting to the PDMP program. So a lot of what you're going to hear today is not too far out of line with what many dispensers are doing through the PD prescription drug monitoring program, for those of you who are unfamiliar with the term. Okay, we'll travel along.
Great. So next, as I mentioned, I'm going to discuss a comment that we received, and Nikki's going to have the portion of the regulations on the screen, and then we're going to talk through the particular regulation.
And for those of you who are tracking to the reg, what we have found, and at least we've heard, it's easiest to find where we're going if by looking at the page number at the bottom. So we'll try to make sure you get to see that, even though we're going through section by section. But it might be easiest for you to, if you wanted to keep up on paper. Also, the highlights represent areas of discussion as well. So they're kind of a legend to give you a sense of what we're going to bring up. So little orientation. So back to you, Anna.
So we are on page 53 for those following along. So the comment we received was regarding a timeline question. So the 60-day time frame from November 1st to December 31st allowed to make necessary modifications and reporting may not be sufficient. At least 90 days for annual modification is needed, moving the approval of the MHCC non-controlled prescription drug dispenser data submission manual to October 1st of each year to be used for reporting in the subsequent calendar year. So this comment is specific to regulation 13B2. In our regulations, we propose that annually MHCC will update a manual that will be available for dispensers to guide them in the reporting process. And in the regulations, we are proposing by November 1st of each year, that manual will be available. And dispensers would have until the beginning of the next calendar year to implement those changes. So I'm interested to hear from dispensers on the call. What concerns do you have with the 60-day timeline? And could you elaborate a little bit more on why the additional 30 days may be helpful?
Hey, Anna, it's Crystal Chisholm from Optum Insight, and this was actually my comment. My designers just felt like they needed a little bit more time than 60 days, that preferably a 90-day time frame would be more helpful. We understand that, you know, the commission wants to get those dispenser guides out, but we just felt having a little bit more time to put those changes in place would be helpful for us. Thank you.
And Crystal, just to make sure, your recommendation is that the manual will be approved by October 1st of each year. So not necessarily changes would need to be in effect by February 1st. And is that to allow dispensers time, knowing the beginning of the year could be particularly difficult to implement changes?
Correct.
Okay.
And Anna, could you orient us to the on the prescription drug monitoring program on the dispense manual? Do they have a 90-day run room, or is it 60 days as well?
So I don't believe they have a requirement in their regulations to update the manual on any regular basis.
Okay, so if we were to propose a change to October 1st for January 1, does that pose a challenge for anyone? Sometimes, oddly enough, sometimes folks see these, you know, moving the dates one way or the other presents different kinds of challenges. Would there be any concern from the group if staff were to make a proposed modification?
Hi, this is Heather Cartwright from CVS. For us, it would be challenging for us to make those changes for a January 1 effective date on an annual basis because we do have IT freezes around that time of year.
So it's not date specific. I think you're saying that if we were to add 90 days in advance, you'd want to shift it so it's not on a calendar year necessarily. It could be on a sort of what we call a quarter of the year. Is that what if it were like beginning of Q2 every year, and I'm just talking out loud to make sure we understand your challenge, that would eliminate the January probably first quarter freezes that you might have, or does that not help?
For CVS, that would help.
And how about for anyone else, if we were to take a different approach and align it on a quarterly basis, does that pose challenges? And I missed what was in the comments, so
Hi, this is Gina from Walgreens. I'm the one who popped in the comments. Can you hear me?
Yeah.
Just like CVS, we also have code change freezes during the holidays. And January 1st is when most third-party changes are implemented, and our stores are already overburdened with work during those times. It's just the nature of retail, and it would be difficult for us to implement those changes in January. If there could be some other type of time frame, or we had an extended, like a 6-month warning, so to speak. So you notified us ahead of that time that you wanted something done in January or February. That would be much easier for us to weather.
So I think what we're hearing, and I don't know how doable this is, but perhaps we can talk about the impact of having it on a quarterly basis. And if we're picking beginning of second quarter, Anna, from your experience, would that create a burden on staff or on the dispensers as we change the manual or consider changing the manual?
I think that should work for us as well. I think our general changes from year to year to the manual will be minimal, unless we shift to a new ASAP standard. And then if we do that, we will inform dispensers as soon as possible, but knowing that that could take additional time. And good.
No, I keep going, please.
And Gina, I noticed in your comment you also had asked a question about a waiver system.
Mhm.
There is a waiver option in the regulations as well, if
Okay.
there isn't a possibility of meeting that timeline.
So I think to be clean is probably the best approach. And if we were to go with a quarterly, say a Q2 adjustment to the dates, and then if we were to propose the changes on 90 days, and we did it, say, in December, does that result in the best of all worlds, if you will, that it gives you enough time going into it? You're also on the backside of your code freeze timeframes. How does that sound to the group?
Can I just clarify one point that you're making? You're saying quarterly. Am I to assume you're just meaning one quarter? I would hate for us to go to updates every quarter, because that would be definitely a challenge.
Absolutely.
One quarter.
So I think what I'm suggesting is that we move away from a calendar year process,
Perfect.
quarter timing, if you will, and we would aim for on the backside of the freeze conclusion for code freezes for the dispensers, and we would look at communicating any changes to the manual in December, and then having it go implementing it, if you will, by beginning of Q2, the first day of the month. And it's kind of an unusual time frame. That's why I was asking lots of questions about it, because we typically would think of fiscal year or we think of calendar year, and this is neither. But if it doesn't pose any challenges to dispensers, then I can't imagine it's not something we could figure out a way to address in the
This is Melissa Patrick. I'm calling from Express Scripts. I do like the quarterly thing, because we also have code freezes in January as well as ORT. But I think one thing that you mentioned just now, where you said it's the first day of the month, and that can be a challenge because if it falls on a weekend or a holiday. So I think maybe more of like the first Monday or the first Friday would be definitely helpful as well.
Yeah, absolutely. We would not want to target for Saturday, Sunday, or holiday. We'll make sure we add language that speaks to perhaps the first business day of a month or something along those lines of the quarter. And where we have run into where there's been overlap, I mean, I think the concern is allowing some practical flexibility. So I don't imagine we can't write this in a way that allows for that. Good feedback. Thank you all. It's funny. I don't think I saw anyone make that. I mean, I didn't see it widespread. I was not aware that dispensers have a widespread coding freezes at the beginning of each year. Go ahead, Anna.
The next comment is on the same topic. So on the same regulation, actually, Nikki, so we're gonna stay on page 53. And there was a suggestion that instead of the manual being updated annually, it should be updated every 3 years, absent any emergency situations. Now, we had suggested an annual time frame to allow us updates to the manual staff based on changes in reporting practices or even changes in the technology that may come up throughout the year, including potential new resources available for dispensers that are then updated in the manual to be included. But are there others who would recommend shifting away from an annual manual update process to something a bit longer in time period?
And while you all are contemplating that question, I'll just sort of fill in the gap. I would think, what we were talking about is that if there's no change, there's no change. And what staff would propose at its annual update period is that the manual continue as published, and we're not proposing any changes to it. So there's a process that occurs operationally every year where staff would say no changes or changes, and the commission would then approve that manual for release. But I would think in order to be responsive to a dynamic marketplace, where technology is constantly getting better and better, we wouldn't want to lock it into something that's more than 12 months, because what it could have is unintended negative consequences. Because if there's a standard or there's something that's changed and we're now limited and delayed because the regs say once every 3 years, once every 2 years, it could actually have a negative impact, I would imagine, on dispensers. So it's probably better to be dynamic, but not expect change every year. Because I think what Anna's saying is, if there's change, we'll bring it to the group. There won't be any surprises, because we would be working with dispensers to identify those changes, and if there are none, then that's that. We certainly don't want to create unnecessary work for anyone, including ourselves.
Hello again, this is Gina from Walgreens. Would you consider aligning with your state's PDMP adjustment schedules? They're usually 2 to 3 years that they make changes to the data elements that they follow, because we would be reporting on the same structure, only a wider collection for the HIE versus just drugs of concern or controlled substances to the state.
So we should definitely explore that. But Anna, Anna has lots of experience with the PDMP. What are your comments?
So the Maryland PDMP doesn't have a set schedule developed on when updates do occur. It has typically been around 2 to 3 years, and especially something as big as changing in an ASAP standard, we would coordinate with them on when that would happen. I will say we're going to spend part of today's meeting going through the manual, and I wanted to point out where the areas are in the manual that differ slightly from the Maryland PDMP, and that has to do with the validation rules. But then also I want to highlight how much we've tried to make the process as similar as possible for reporting to the Maryland PDMP.
Yeah, so maybe we can talk, but I think your comment is a great one. Why don't we take this as a takeaway? We're very fortunate today to have at least one of our super great assistant attorney generals on the call with us. And she's been tremendously helpful in giving perspectives as it relates to what can be in reg and what should not be. Maybe there's a way we can build in a flexibility that says whenever possible, we seek to align with changes in the PDMP, but to Anna's point, it's not entirely possible all the time. But I think the group is saying, where you can, please try. I think that's what we're hearing. Would that be a fair representation of your comment?
Yes.
Thank you, Gina. Are there others on the call?
Not a problem.
Okay, hearing none, I think we can move on to page 54. And so we have the top of page 54. This is the portion of the regulations that describes what elements of the manual or what components are included in the manual, and the highlighted portion is require a dispenser to report data elements consistent with the American Society for Automation of Pharmacy, or the ASAP standards. Now, we received a comment that was a recommendation to further specify the ASAP standard to be used by dispensers. Now, I will share that we have the ASAP standard specified in the manual. The draft manual includes ASAP standard 4.2b, which does align with the current PD&P standard used. And our instinct is to not specify in regulations an ASAP standard, just given how much time it can take to update regulations, as well as how often ASAP standards change every few years. But I don't know if there are others on the call who have had experience of working with states in which the ASAP standard is specified in regulations and they are recommending it.
Yeah, and I would also note that whenever you embed a standard into regulation, it can, if the standard doesn't change and it's pretty stable, by and large, it doesn't create challenges. But where it's dynamic, such as in the pharmacy world, you have to be careful with that. I think Kevin has his hand up.
Yeah, hi Kevin, I was hoping you could speak to this.
Thank you. Just a minute, I've got two phones going. I would suggest just modifying the language a little bit as you have it, consistent with ASAP standards as listed in the current published dispenser model, something like that, so that there a dispenser says, well, it's just ASAP standards, I'll use 4.1, or I'm doing 5.0. That way it still says ASAP, but according to or pursuant to the currently published guide.
Yeah, I think you're saying the most current version. And this is where our AAG can help us. But I think your point is well taken, which is it's the then current. Well, actually, it has to be. Well, I guess we really have to, Kevin. We'll have to talk to Alexa to help us a bit more, because you're saying the current published version. That could be tricky because I feel like, well, how do you keep, I mean, what if you fall behind? How do we know the current version? Yeah, right. And I think Sasha's point is the timing that you need to adopt the version. So it can be, I think your point is perfectly well intended, but the operational piece of it could be tricky. So I think within our notes, it's, how do we make sure it's the most current? How do we allow enough time to give folks the ability to implement the standard? So it could be a little more trickier than we think. Kevin, is there a way you would approach that?
Yeah, my thought is that the language is pretty good, but there's an opening or a gap that you have that a dispenser could say, because it doesn't list the ASAP standard in regulation, whatever you have published is the ASAP standard used. And so you're not really changing anything, you're just more accurately clarifying or defining what that ASAP standard is by something that you've already approved on.
So Alexa, can you weigh in and give us some guidance here?
So, I mean, maybe I'm misunderstanding. I just want to note, like, this section of the regs is just specifying kind of the details that need to be spelled out in the manual. There's other sections of the regulation that would require dispensers to report in accordance with the manual. And so the manual would specify the ASAP standards that dispensers would need to use. It just wouldn't be specified in the regulations.
Good point.
Does that make sense?
Yeah, and that's a great point. Thank you. And Sasha, would that answer your question too, by the way? I think what Alexa just shared with us feels like it does. but you tell, if you can speak to that, it would be great.
My concern was just if we add regulatory language that says the most current version,
Mhm.
then the day a new version comes out, everyone would have to use it,
That's right.
which is not practical. Obviously, there would need to be a timeline for adoption,
That's right.
but I'm fine with the yellow highlighted language if we do not add the most current version, because I think that was the part that concerned me.
Yeah, good point.
And I think my comments weren't clear enough. I don't mean to use the most current ASAP version. I mean to use the ASAP version that is defined in the most current dispenser guide published by Maryland.
Yeah, there we go. Okay, I think that's probably a better strategy.
Yeah.
And I think that's what Alexa was suggesting.
Yeah.
Yeah, and I think it does say that elsewhere in the regulations that dispensers need to report that in accordance with the manual, most current manual.
Yeah.
And yeah, I think A or the first. You move up
There it is, at the bottom.
or in accordance with the regulation, or sorry, I know it says it somewhere, but I will double check and make sure.
We'll make a note, yeah.
Yeah.
Cool, thank you.
All right, thank you, everyone. So our next comment is on the top of page 55, Nikki, so. This has to do with the timing of reporting. So the regulation states unless granted a waiver under this regulation, a dispenser shall report non-controlled prescription drug information to CRISP, including 0 reports at least every 24 hours. We received a comment suggesting updating the reporting timeline to every 48 hours rather than every 24 hours and addressing corrections every 5 business days instead of 3, which I think is also addressed later on. So,
And Anna, can you remind, as the folks are thinking about their question specifically, remind us how the PDMP operates?
so right now, the PDMP regulations have a reporting every 24 hours and then addressing errors every 3 business days. Now, this comment could have come from someone who may be newer to dispensers, but we're hoping to hear from others. Would adjusting this timeline be particularly helpful for dispensers? Changing every.
Yes.
Go ahead, Gina.
Hi. Rule of thumb normally is it's 24 hours or within the next business day after being sold. I don't know if that's a distinction anywhere in the regulations, but we normally don't report things that haven't walked out the door, so it has to be sold. And normally it's 5 to 7 days for a correction because it's not always immediately brought to our attention. And again, I'm not sure if it's in here. We need to know the manner of expectation for corrections.
Yeah.
If you're going to have a tool for that, or if we have to build one.
That's a good point, and that level of technical detail we have currently in the manual, but that feedback is also helpful with timeline.
Yeah, but it's in the manual, it's specified. I think that's something we didn't want to build into the reg. Again, it becomes less fluid. It's harder to change that way. But so Gina, so how are you currently handling the PDMP reporting?
We have a vendor partner that we work with that we send them our med history file and then they disperse that to whoever the state's vendor partner is.
And is it different than what we're talking about here?
No, these would not be any different. We would just be sending the information to a different location, right? It'd be going to the HIE.
So I can speak to that a little bit. So we've been working with CRISP to establish that process, and the goal is for their vendor to be able to accept one file with all dispenses, and then they would be sorting it from CVS to non-CVS.
Which goes to minimizing the reporting burden.
So then there wouldn't be an expectation on dispensers to create 2 separate files. I know that there was some conversation with a pilot, and the pilot suggestion was to create 2 separate files. But when the regulations are final and this process is rolled out statewide, it would be 1 file, 1 process.
And can we go back to the 24 hours? Is the 24 hours doable? I thought I heard yes, and then I thought I heard no. So, I mean, I think what we're saying is it aligns with current reporting. So, I think that's the strategy. And I don't know if it was Gina or someone else who said on the 24 hours, we needed more language to make it clear that it has to be somewhat tied to the sold component. Is that what we're hearing?
That's just what I'm familiar with. My background is really with the PDMP reporting. And usually the language is no later than the end of next business day after the dispensing of the product. So that would be sold.
And Kevin, can you just share with the group how Oklahoma, I think you said Oklahoma's handling it?
Yes, Oklahoma for several years has been requiring reporting every 5 minutes from the prescription being sold. Missouri has legislation, and I've not kept up to know if that's gone into effect yet. It was supposed to have, but they were also going to be doing that. Nebraska doesn't require, but voluntarily allows dispensers to report within 5 minutes, and that's going pretty well for those that are. But I like the language that Gina was thinking, just to clarify, what does every 24 hours mean? Is it 24 hours from the last report, which you could almost be 48 hours out, or at least once every 24 hours from the prescription being sold, which from my experience seems to make sense.
Right. And Sasha, was what Kevin's reporting, would that address your concern?
I'm not familiar with the real-time submissions that happen in some states. The feedback that came up from us is that in some states, for a PDMP submission, which is a smaller volume of prescriptions, sometimes there's a manual review of the file that has to take place. And if we extrapolate the volume of a file with all prescriptions in it, not just the controlled substance prescriptions, it's going to be an extremely large file. And so the system can submit it automatically, but if there needs to be any manual review, this is going to be a really big file for the pharmacy to review manually. If there's no anticipation that manual review would ever be necessary, that's not going to be a burden for the pharmacy. But if that ever is a case, and I know it is sometimes for PDMP submissions, then the pharmacy would have a really long file to be looking at, and trying to do it every 24 hours was just the thing that we flagged for them.
And Anna, is it in the manual? I can't recall. Does it address the manual review of a file? I mean, is that, I didn't think, but you correct me here, that there's a requirement for a manual review of the file.
We don't have a manual review requirement in the dispenser manual set out. Sasha, could you speak a little bit more to that manual review process and the types of things the pharmacists are looking for?
I'm not familiar with the details, unfortunately. It was just a caveat that came up about the time frame from my colleagues.
I can speak to that. This is Dan from Epic. I work with Sasha. The context that came up in was that sometimes we get errors from PDMP submissions. So if there's a mismatch of some information, or some information doesn't get formatted quite correctly, that can require manual review and manual editing to resubmit that file. And so that was the concern there, is if you assume maybe for example, 0.1% rate of needing to go through and manually tweak the text in that file that gets submitted, that could blow up to be quite large if you're submitting every prescription.
And Daniel, just as a matter of opinion, what do you think a reasonable time should be?
That's a tough question, and the thing that came to mind was maybe not so much about a turnaround time there, as in if it matched exactly the PDMP submission file. I guess I don't know what it is for your state there. Like what the average rejection rate is for prescriptions submitted to the PDMP, but that might be worth looking at and seeing if some of the criteria for whether dispense reported is rejected or not could be loosened, or something to address that manual work needed when the dispense reporting is rejected.
Yeah, and I actually think, if I remember right, and Anna, Anna comes to us from years of experience on the PDMP. We stole her away a couple years ago, and I feel like with the data I see, the rejection of the files is fairly low. Is that, do you believe that still holds true, Anna?
The rejection of the file is fairly low. There's it depends on the specific variable, how often an error, which would reject a dispense. But we can look into it a little bit more. I know the PDMP's working with their vendor on coming up with some innovative ways of looking at that recently.
So before we leave this, would it be possible to think about when there's a resubmission that it's, the requirement remains the same, but if a resubmission is required, there's more flexibility around when that needs to occur? I mean, with that, I think, Daniel, to your point, and Sasha's, would that be enough of assistance that you would say, okay, that makes sense?
So instead of correcting errors within 3 business days, correcting errors within maybe 5 or 7 business days.
Sasha, or Daniel, what do you think?
I can't say exactly if that would, if the error rate and rejection rate of the individual dispenses is low, then that sounds reasonable. I think then if the numbers, you look at them and it actually turns out, well, it's, 100 rejections a day, then even if there's that extra turnaround time, that doesn't necessarily solve the problem. So it really depends on what the actual volume of errors coming through would be.
Yeah, that makes sense. Gina, you're probably closest to it, I would imagine. What do you think about some relaxation in the reporting time for?
Yeah. Of course, because like we said, we're not always notified immediately. We don't know how those correction requests are going to come to us, right? Right now, we're only reported through the store or the boards of pharmacy. Our only focus is on the controlled substances or products of concern. So we still have to determine those lines of communication as well, as to how those are going to be. And the volume is going to be significantly greater on top of the work we already do for all the states, not just for this one specific state, and any extension of time would be appreciated. If it's something simple like a missing phone number or something like that, where it doesn't really affect the data, then, a bigger window. But if it's a wrong doctor or a wrong patient, of course, those are going to be handled with a little more critical care, but still fall within that time frame to get those corrected.
So we'll aim to expand the time to 7 days, something in that area. I think and then you all can chew on it if we think it needs to be changed a bit more. There's still opportunity.
Yes.
Great feedback.
Great. So our next comment is the bottom of page 55. So this is similar to the discussion we just had on addressing errors. So if data are submitted by a dispenser, the dispenser shall correct. We just discussed extending this timeline. We did receive a comment related to this process of addressing errors, suggesting that the manual include instructions on how dispense information should be reported to reduce errors sent to the state designated exchange. So as I mentioned, we're going to pull up the manual in a few minutes and I can go through some of those validation rules and how those, especially those that differ from the prescription drug monitoring program in Maryland's requirements. So I think we've talked through this one well enough.
Yeah, outstanding. Thanks, Hannah.
Okay, so the next one is in regards to how the data shall be used. So, so Nikki, at the kind of the top of page 56, so the data collected under this section for programs led by healthcare providers to identify opportunities for quality improvement pursuant to a court order, subpoena, or for other public health purposes as allowed by law. We received a comment suggesting making the purposes for which the data can be used broader to include anything allowed under applicable law, including care coordination and quality improvement. Also suggests specifying limiting access to disclosures required under applicable law. So
So I'm not sure I understand actually what the commenters, now that I hear it out loud, I'm not sure what are we getting in this case? I mean, what does it really do? I mean, I'm trying to figure out who benefits from it. I mean, is this a provider, is it a consumer, is it a dispenser? What for the individuals or individual who made this comment, can you give us a bit more input?
I'm looking for them. I'm not sure that they are on the call today, but kind of a broader question. Are there concerns with how the use cases are described in the regulations by those on the call?
So yeah, I struggle a little bit, but we'll try to follow up separately with the commenter and see if we can gain a bit more insight, because now that I hear it, we talk through it, I'm not sure I understand what either benefits or harms could be caused by a change. I mean, it seems pretty clear to me. So but we'll follow up independently with that individual. So.
Right, and then the last comment we wanted to talk through today was regarding the waiver process. So that's a little bit farther down on page 56. So Gina, to answer your original question, this portion of the regulations describes the process in which dispensers can request a waiver. And one of the reasons in which a dispenser may seek a waiver is for dispensing less than 100 non-controlled prescription drugs annually. So the question we received from a commenter is the fewer than 100 non-controlled prescription drugs exclusion counting prescriptions or fills. And so just to specify, this is going to what dispenses are actually occurring from your location.
Okay, I was looking more globally as an organization. If we are in good faith actively trying to meet your deadlines, but due to resource constraints, IT issues, if we can apply for a waiver and that, like, we can't meet February 1st, but we'll be ready by March 22nd. I'm just throwing arbitrary dates out there that we are trying to meet your deadlines, but we are not going to be able to make your hard date. Is if we show that we're actually actively working towards meeting that. Do you have a waiver process for that? We do have other states, again, for PDMP reporting that allow that, as long as we're in communication with them, that we are trying to meet their goals. We're good.
And Gina, does E here seem like it addresses that for you?
Yes, as long as that, we're in some kind of agreement, or you might need different language in there. What's extenuating? I've seen other regulations where your system's down, there's an IT failure, they're a little more delineated as to what, because extenuating can be it's very open to interpretation. And depending on who you talk to, you can get a yes or you can get a no.
So we may need to, what you're saying is there a way to define extenuating circumstances?
Right. Just be a little, thank you, clarifying a little more clear on what you consider to be extenuating.
Okay. I guess that
And-
seems reasonable. The thing I wonder is if you define it too specifically,
Yeah,
it cuts both ways, right?
yes,
Yeah.
I agree.
Evan, are you wanting to add to this conversation?
Yeah, I have a couple of comments regarding the waiver, not so much the process, but the criteria. Speaking not only as a healthcare professional, but a former PDMP administrator who has dealt with the challenges that smaller dispensers may have and the complaints from healthcare professionals, that one of the main things we always looked at and heard is that missing or inaccurate data severely hinders professionals from understanding the reliability of the system. It just takes one doctor to see, oh, there's a missing prescription. All the PDMP data cannot be trusted, therefore I'm not going to use it. That's the extreme case. Trying to limit the waiver criteria, I think, would be best. And we've worked with the smaller pharmacies that may only do 1 or 2 scripts a week, which fits some of this criteria. And we were able to work with them. There are processes in place that are not burdensome when we've spoken with them. The economic hardship, I think, that's pretty broad. And trying to balance that economic hardship with patient care. What do the healthcare providers want or need? Is that balance you'll have to think about. Same with technology limitations. Very, very few anymore. Once again, we have close to 1,000 dispensers in Nebraska, and there are very, very few waivers. Mainly it's for other statutory issues, but trying to get as complete and accurate information is always what you're trying to accomplish. Trying to minimize what the perception from providers, you're missing 1 script, therefore the whole system is unreliable and cannot be trusted. That does happen. I've heard it on more than 1 occasion. So trying to work with those dispensers that do very small volumes, I think, would be better than just automatically giving them an exemption.
So I think, Kevin, those are excellent points. And we probably can talk more internally, but I think the categories are intended just to be relatable to what you could encounter. So there are more guidelines. Yeah. I don't believe that, and just because I don't believe every request for exemption will necessarily be approved. I think, to your point, it creates opportunity for dialogue. It creates opportunity to try to help resolve the challenges. And if they are approved, it could be time limited or circumstance limited. I think I hear you. But we hear that comment about health information exchange all the time, just in general, or even electronic health, the quality of electronic health records. So I'm not sure we can ever dispel the folks who wouldn't speak favorably about anything electronic in healthcare. But I think we hear your point, and we can talk internally to see if there's any way to address this, or if it just has to be, the regulators have to be responsible, and every request doesn't need to waiver. It has to be, reviewed and considered. We can talk more, but I think there's a couple other comments. And Sasha, do you want to make your point, and then we'll come to Patrick?
So I think Daniel and I just missed what Anna said about C, which is highlighted on the screen, but we had asked whether dispensing less than 100 non-controlled prescription drugs annually referred to fills or dispenses, or fills or prescriptions. And I thought you said fills, but I just wanted to confirm because that was our question.
So it would be dispenses. So I think we know that sometimes a prescription is filled in the pharmacy but never actually dispensed. And so a lot of the regulations in the statute language is around what has to be reported regarding when a prescription is dispensed. So we made the waiver criteria specific to how many dispenses occur from a location.
And isn't that, and Sasha, to your point, isn't that a better strategy? It kind of, it seems to be more relaxing requirement.
That wouldn't you have more dispenses though? If you,
Well, I think it fills. I mean, if you fill 100 and you only dispense out, 75.
right, I think prescriptions would be the smallest.
So by prescriptions, are you referring to prescriptions that are referred to a pharmacy?
Yeah, I'm just
Okay.
thinking through how you would count it. I don't have an inherent problem with dispenses. I was just, I don't know that I think that's easier. But I think we mainly just wanted clarity.
And maybe Gina, you've been our go-to person here. What are your thoughts? And then Patrick will come right to you.
I'm sorry, you're gonna have to repeat the concern.
Well, does it make sense on C, which is highlighted,
Mhm.
is considered to be one of the waiver categories, and it's this or consideration for waiver, and it's on dispenses. That
Oh,
means
right.
not bills, but dispenses. So the thinking here.
So to
is-
me, dispenses is what walks out the door,
is that-
right? We've sold it.
yes.
And it feels similar to other waivers for other states where they do such a low volume. Again, I think Kevin had something, the burden on these smaller locations can be quite high. And I mean, that's really up to you. Do you really want to know about that less than 100 annually? Some states have it a month. So you might want to consider the time frame on that too.
Right. So thank you, Patrick.
Thank you. Hello, everyone. My name is Pat Canoe. I'm with the Prescription Drug Monitoring Program Training and Technical Assistance Center. Kevin and I work together. Anna, I was in the language under number 4, I think it is, a little bit farther down on the page, 4 and 5. So you're going to approve or not the waiver. And then under number 5, it says that the dispenser shall inform the commission and immediately begin reporting in compliance with the section when they no longer meet the conditions of the waiver. So in number 2, you list out the conditions. Number 5, if those conditions change, then the dispenser is supposed to start reporting. How are you going to verify the conditions are being met other than the person's word? And how are you going to verify that a dispenser is no longer in compliance? And is there any penalty if they misled, misstated, deceived on the waiver request?
Yeah, so I think that's a good question. I mean, there are requirements in here, to comply. I think I have to go back through. I don't remember. Alexa, is there a pen? Do we have a penalty included in this reg? I don't recall off the top of my head.
I would need to go back through. I mean, I know we have kind of general penalties under this entire chapter for related to HIEs. I need to go back through and look at the application.
So we can come back to that, but it's probably not unlike how other states are doing this. And there is some responsibility for the dispensers to be, to attest, to be accurate, to if you're putting some
Yeah.
request in writing, you're attesting to that. And there probably is some way methodology in an exception that's approved to note the requirements in the reg about re-reporting. But I don't know that we can be more definitive, but this is a takeaway for us as staff.
Okay, yeah, and I understand. I used to be with the over the Texas prescription program many years ago, and when we put in some waiver conditions for reporting, unfortunately, we found that not everyone was honest, and we did not discover that until there were routine audits by the State Board of Pharmacy that showed us that people had been less than honest and forthcoming with us. So just throwing it out there. I'm sure the people in Maryland are more trustworthy than the people in Texas, but just throwing it out there.
And I'll just ask Anna to come back to her days at the PDMP. Did you find that there were cases like that when exemptions were granted? And it doesn't have to be for dispensing, but did you find that it turned in it? Was that a frequent problem? I'm just curious more than anything else.
So there wasn't a waiver allowance with the PDMP in Maryland. We had found when looking at compliance data, just checking to see based on who has a DEA number to dispense and checking to see how often they were dispensing or reporting that they were dispensing, that sometimes didn't match up, and sometimes it had to be a follow-up conversation of, hey, you remember that this is a requirement in the law that you need to report. So there could be some of that. I also wonder, Pat, if making the waiver time limited and them having to attest it on a more frequent basis.
Yeah, in Texas, we did an annual renewal of the waiver.
Oh yeah, I mean, we would absolutely want to have this based on some time factor. We weren't thinking that this would just be open-ended and
Right.
yeah,
Okay.
it's time, and perhaps we need to spell that out in the reg, make that clear. It's based on some time. But there are some audit controls, now that Anna mentioned that the staff, even on waivers, we could periodically conduct some audits using data that's collected to figure out whether or not somebody who's saying they're not meeting, they don't do 100 scripts to determine whether or not that's actually the case.
You could also always see if they're dispensing 100 controlled substance scripts. That's another option, but yeah.
Thank you.
No, thank you, Pat, for that recommendation and calling that out and basing on your experience. It's helpful.
Great comments.
So those were the comments related to the regulations that we wanted to go through today. Are there other questions or other comments regarding these regulations before we move on to a different topic?
So this was very helpful. Your all's feedback was extremely guiding, and we have some takeaways here. And fortunately, it doesn't sound like anybody was saying these regulations are impossible. I think we got really good feedback on certain aspects. It'll help us as we try to do a bit more reshaping of the sections of the informal draft. And
So, go ahead.
Anna's going to be taking us to the second segment of the discussion today. It's probably, everyone is welcome to attend, of course, but it's going to be a bit more technical walkthrough of the manual at a high level, the data submission manual that's been drafted. If you're interested to stick around, we'd love to have you, but if you're, to that end, if you're time limited and lots going on, then we won't take offense to you saying goodbye, and perhaps we'll see you at the next working session, which is coming up next week on the 30th. So Anna, back to you.
So many of you have seen the draft manual, and we are busy incorporating the feedback that you have provided to us so far into this version. For those who haven't seen it, I did want to take a few minutes just to walk through it and also let you know that this is going to be released for another comment period. We're hoping in the beginning of August soon. So It should look very similar to other manuals for PD&Ps in other states. Just going through the table of contents quickly, we have a background section, a section on the data collection and reporting requirements. So defining dispensers again, defining reporting timelines, and we'll make sure that it aligns with what we just discussed with the regulations. What information needs to be reported, and then what happens if there is a mechanical, electrical, or other technical failure. And then the manual goes into the more technical process of how to create an account, how to maintain an account, system notifications. Then there are 3 methods in which data can be submitted. These are the same methods that are available for the Maryland PD&P, SFTP, which we know is the most common method for dispensers to report. There is a way to upload a file directly onto the portal, which is RxGov. And then also there's a way to manually enter dispense information, each dispense in the RxGov portal as well. We have a portion of the manual on the validation rules, which I'm going to spend a few minutes on to let you know about and how they differ from the PD&P. There's a process on how to view and update submitted reports. There is a section dedicated to zero reports in this manual. I know we received a few questions about that and if that could be described, and that process is described here. And we've even added an Appendix B that adds additional specifications on how to submit zero reports, where to go for assistance, and then also the data standard. So this is a longer document. I apologize for scrolling if it makes you nauseous, but I highlighted a few things I wanted to point out to this group. So dispensers who already submit CDS dispense information to RxGov as required by the Maryland PD&P the goal is to work with our vendor to make sure that you're able to submit non-CDS information in that same file, in that same process that you're submitting CDS dispense information. We talked about a reporting timeline, which we can update to align now with the regulations. And I specified here the ASAP standard being 4.2b is the one we anticipate starting with. I know there's a handful of states that have shifted to 5.0. We anticipate aligning with the PD&P standard at the moment, which is currently 4.2b. And then this is the language that we'll also update about addressing the error correction timeline. So I wanted to note one thing that we're working on with the vendor is that if you're already reporting CDS dispense information, you will not have to create a new account to also report non-CDS dispense information. You can submit it within your own account that you have. So a lot of the creating the new account information, hopefully these aren't steps that many of you would have to go through, since you can use your same submitter to submit information. All right, so we have the different submission methods, with SFTP being the most common one. We're working on improving some of these images so they look a little bit crisper and easier to see, which is some feedback we got from dispensers. And we're working with the vendor on that. We added some clarity, or we're working with them to add some clarity on that SFTP process, noting the exact location. So for the validation rules, this is where I wanted to talk through what's different for the non-CDS dispense information compared to the CDS. So when you submit, all of you know very well that who are already submitting, but you'll either receive an error or a warning in the RxGov platform. Errors indicate that a dispense was rejected. A warning indicates maybe there's something not quite right with that information, but the dispense itself wasn't rejected. We're encouraging you to update that, but we're requiring the errors to be corrected. Now, here are the few situations that are unique to non-CDS, and this is based on feedback we've heard from the non-CDS work group that we convened in 2022 and 2023. So for dispenser ID, that's PHA 01 or PHA 03, we're requiring either DEA or NPI to be reported. And similar for prescriber ID, either DEA or NPI to be reported in PRE01 or PRE02. For patient identifier, we heard from dispensers that this is not always collected for non-CDS. You go to a pharmacy to get a prescription filled, and unless it's a controlled substance, there's a good chance that you don't have to show an ID. We did want to require that if an ID is submitted along with the dispense information, that the ID qualifier has to be submitted. That way we are not receiving a 10-digit number and not knowing, is this a phone number or is this a license number?
And Kevin, your thoughts here? And
Sorry, couldn't get off mute. On prescriber identifier, do you want it to say that an NPI can be sent, or if it's a controlled substance, you want DEA? Or are you saying even if it's a controlled substance, an NPI is sufficient?
So this is where we're going to have a manual for the PDMP requirements and a manual for the non-CDS requirements. So the manual for the PDMP requirements managed by the Department of Health will specify that DEA is required. But that's a good note. I could put a reminder here in the language.
Okay.
Yeah, for a reminder of what is required for controlled substance.
Okay, thank you.
So, Anna, this is Melissa from Express Scripts. We also do pet medications, and a veterinarian won't have a DEA or an NPI.
So one thing we were able to discuss with the vendor is if species code that PAT 20 indicates the prescription was written for a pet, all other validation rules would not be applied. So that would be one of the first things look for. If prescription for pet, then that dispense is kind of moved off to the side, and these other requirements for dispenser ID, prescriber ID aren't required.
That's right.
So hopefully that addresses the concern with the pet dispenses.
Okay, thank you.
And then similar, when I was with the PDMP, I noticed often sometimes product ID would be reported without a qualifier. So we would know if something was milliliters and milligrams. So we're requiring, if product ID is reported, product ID qualifier is also required. And then, as many of you know, if the dispense is for a compound drug, there's a specific set of requirements just for those compound drugs. So I grouped these particular validation rules together because there's dependencies on all of these, whereas other ones, it's either required or not. These are required depending on another variable. And this is further outlined in Appendix A, which is the table near the end. I apologize if this is making anyone nauseous. It's a longer document. Here we go. So this should look familiar. It's the 4.2b ASAP fields. We have an indicator here if the field is required. I've added if the field is missing, if it produces an error or a warning, or if the field is entered in an incorrect format, does it produce an error or a warning? And hopefully this helps in addressing error concerns as well. And when there's a field like the pharmacy ID, so we have an R asterisk. So either PHA 01 or PHA 03, the NPI or the DEA are required. I'm glad the additional column headers are helpful, Heather. That was one of those things that always kind of I wanted to add. I'm glad I was able to do that with this set. So there's some situational fields that produce a warning. For instance, phone number. This is one of those areas where we're not going to require it, pharmacy phone number, but this is something we want to track. One way for us to track how often this is missing or in the incorrect format is to have warnings attached to it. And then also it's an encouragement to, if you have pharmacy phone number, please include it, but not required. It's a nudge. And then, as I mentioned, this document will be shared widely. I'll let everyone on this call know when it is available to review. And I would love to get any additional input you may have on it. I know many of you have seen it. Hopefully the feedback that you have shared with me so far, you'll see it being incorporated. And then a new Appendix B has been added that specifies which fields are required to submit a zero report and some specifications on how to submit a zero report as well. So are there any questions about this manual? I know I went through it pretty quickly.
And Anna, can you give us a target of the release for comment?
The target for release is mid-August.
And we would hope to get comments turned around how quickly?
2 weeks.
Beginning, you were talking about submissions in terms of the controlled substance versus non-controlled substance, meaning that they would only have to report one data set. Can you explain that a little bit further in how that would be handled?
I can, yes. So if you're preparing one file to be shared via SFTP to go to RxGov, you can include both CDS and non-CDS in that file. Now, I will say some of these validation rules are slightly different, and especially the ones I just discussed. The species code, for instance, wouldn't eliminate all other validation rules for the CDS dispense information, for example. And they're requiring for prescriber ID a DEA number instead of DEA or NPI. But instead of preparing 2 separate files to submit via the SFTP, dispensers can submit one file. You're welcome to submit it in 2 separate files if you would prefer. But we thought it may be helpful as an option to submit it as one.
Thank you.
Melissa, your thoughts?
I'm very happy about that, so I'm clapping.
Oh, very good. Well, that's good to hear. Okay, Anna, thank you. Great job walking us through. And I think that brings us to the end, a couple additional next step announcements. So, and I'll turn it back to you.
Great. So just a reminder, the feedback on the comments and the regulations we received today, we're going to take them back, consider them internally. If we have follow-up questions, I know there was 1 or 2 comments we may have follow-up questions on, we'll reach out to you directly on the regulations specifically. And we aim to publish the regulations in the Maryland Register in this fall of 2024. Now, for those on the call, we will have one more working session on July 30th, next Tuesday at 1 p.m. Eastern Time on the reporting of electronic healthcare transactions as required by Chapter 790 and 791. And I will be sending out a reminder and another registration link for that meeting as well.
So, yeah, with that, I would just thank everyone for your time today. Very, very guiding feedback. So, group, thank you for your time. I don't believe our executive director is on the line at the moment. Nikki, am I missing Ben?
No, he I think jumped off.
Okay. Anna, then I think you want to turn us loose. You want to proceed?
Yes. Thank you everyone for your really thoughtful comments. I always really appreciate working with all of you dispensers on the manual and the regulations. You always have such thoughtful input, and we will be in touch soon with next steps. Have a great
great day, everyone. Thank you.
You too, everyone. Thank you.